Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. A warm welcome to all the respected dignitaries, faculty, and the audience who have gathered today for today's event on this most auspicious Republic Day, 26th of January. Today's program focus, next slide please, is on anemia, and we want to try and eradicate the silent killer. As usual, I would like to begin by acknowledging the AMOG's office bearers, our beloved President, Dr. Rajendra Singh Pardeshi, sir. Next slide, please. Our Secretary, Dr. Sujata Darvi, ma'am. To the ICOG office bearers as well. Next slide, please. Our Chairperson, Dr. Lakshmi Shri Khande. The Secretary of ICOG, Dr. Ashok Kumar. Next slide, please. Thank you so much for granting us the 2 ICOG credit points for this event. Next slide, please. We are delighted to have with us today Dr. Amey Purandare, sir. Sir is the Vice President of AMOGS and he's also served as the Chairperson of the Foxy Food, Drug, Medico-Surgical Equipment Committee in the past. He's also served as the Joint Secretary of Foxy in 2019. We will be having him very soon. But before we go on to the guest of honor, I would also like to take a moment to welcome our chairpersons for today. Next slide, please. We have with us Dr. Mandakini Meg, madam. Madam is the chairperson of ICOG, immediate past chairperson. She's the vice president of EMWI Central Council. She was a vice president of Foxy in 2012. Managing committee member of Mumbai Society, and the unique distinction is that she is the one with the longest tenure. Since 23 years, she has been a member of the managing committee of Mumbai Society. She is also uniquely positioned that the Mumbai Society office was once in the Kama Hospital premises when Madam was the medical superintendent of the Kama and All Bliss Hospital. She is a maternal health consultant for the government of Maharashtra and she's received innumerable awards for her publication. Behind the scenes, she has been instrumental in helping so many OBGYNs silently. At the height of the PCP-NDT issues, she has rendered human service to so many of us and helped to unseal so many machines. It just cannot be described in words how much we owe her. The most important thing is that she is a silent worker for all of us, and we all look up to her as somebody we respect immensely, and we wish her all the very best in her endeavor to as the Foxy President election for 2023. Thank you so much, ma'am, for being here. Next slide, please. I would also like to acknowledge the presence of Dr. Ritu Khanna, ma'am. Thank you so much, ma'am, for taking time out from your busy schedule to be here with us. She's the chairperson of the Foxy Food, Drug, Medico-Surgical Equipment Committee right now. She's also served as the secretary of the Society of Fetal Medicine, UP chapter, also been an executive member of UPCOG, vice chairperson of the Women's Doctors Wing, IMA Banaras branch, Vice President of Varanasi Society 2019-20, Joint Treasurer of Indian Fertility Society 1820, and she's worked immensely for her committee throughout the length and breadth of the country. We are delighted to have her here in a role as chairperson. We have two fantastic eminent stalwarts as speakers for today's event, which is on anemia. First and foremost will be Dr. Archana Verma, ma'am, who served as the Vice President of Foxy in the past. And we are delighted to have with us Dr. PK Shah, sir, who's been a past president of Foxy as well as the Mumbai Society. So without further ado, I would like to hand over to the chairpersons, and Dr. Mandakini Meg is going to take the privilege of introducing the first speaker, Dr. Archana Verma. But in her own inimitable style, she will also want to comment a little bit about the second speaker, Dr. PK Shah. Over to Dr. Mandakini Meg, ma'am. Can we have Dr. Archana Verma's slide on screen?
So good afternoon, everyone, and extremely happy that Pratik has organized such wonderful program on this very important day of our life as Indian, that is a Republic Day. I acknowledge the presence of my senior Dr. PK Shah sir and all the dignitaries here, Archana Verma, Ritu, and Amey, and ICOG chairpersons, and all the, Dr. Pardesi. So it is a really pleasure to introduce Archana. Very difficult to describe and tell about her. A very good friend and the most popular person from the North Zone. She was immediate vice president of Foxy. Last year we have seen her working, and she's also associate member of RCOG. She's a founder president of UP ISOPAV, organizing chairperson of UPCOG, past chairperson of CZB, OBGY Society, organizing secretary of North Zone Foxy, and so many things you can see her. And most importantly, when she was the chairperson of this public awareness committee, I got a call from her, Madam, how to go about it? Very sincere call. And in my own way, actually, I have, tried to guide her. And from that day onwards, it's not only me, but there are many seniors. It was very nice on her part to, take the guidance, and she has done tremendous work. And from that onward, the public awareness committee has become so popular, so much known now. Everybody is after the public awareness committee. Thank you, Archana, for that wonderful working. And even with the CRZ, CRP, police official, cytology, and so much she has done. And also now also she is doing a lot of work, and she is very committed in so many issues, maybe women's issue, anemia, and she has got her own fan following. So I present Archana Verma, and also before I leave this platform, I will like to acknowledge PK Shah sir. Sir is a mentor, guide, philosopher, everything to me. And second thing is, we had a wonderful time as a president and the vice president when we were working in 2012, 13. And I think I have learned a lot from Dr. PK Shah, a very nice, warm, and sincere advisor, I can call him. And sir, thank you for everything. I want to, from this forum, I want to acknowledge your presence in my life as a very positive change. So thank you, sir. And thank you, Pratik. And now I think I hand over the mic to our eminent speaker, Dr. Archana Verma.
Thank you. Thank you, madam. Thank you. And so nice of you to have say so many good words for me. And I will remember, I will frame these words also in my mind, and my OPD also with your photograph as usual. Because I have that photo with you in my, especially Taj Mahal. I will just click that photo and then show you. So, Pratik, thank you very much. And today I can only say that A for advisors and A for anemia and A for awareness. So this advisors group is wonderful, and I think so senior, so respected persons of MOX, and I must say President Dr. Rajendra Singh Pardesi, who has always been almost a front warrior for giving platform to all. And Pratik has been, though he's my friend, but I always call him my advisor also, and my Purandare also, these two people. And Dr. Mandakini Megha, madam, is one person we can rely on. And very sincere, and I must say full of knowledge, and I'm so happy and to give a talk and given a big opportunity to talk before Dr. PK Shah. Oh my God, if anybody can see the pulse oximeter and my pulse, then I think it will be something, this hyper oxygenated report will come. And so please, may I start the talk?
Yeah. You can share. You can share your presentation, please.
Pratik, please help.
I think some technical issues. So Sana from the backend is going to share screen. Okay. Sana, you're ready?
So if today not, we are talking about anemia is something very basic and primary thing. And we all know, and everybody thinks that we all know everything. So let us see how much we know and how much we should know, because anemia perspective is different from a community point of view, from para-health workers, and from medical persons. As a gynecologist, next slide, please. I would like to tell us certain points and that we should take care. Next slide, please. So what the anemia means is it slide is moving? Yes. Okay. So anemia actually basics very simple form of this. Today my talk was given was the oral iron, the Indian perspective. So that is a treatment for the iron deficiency anemia. And for the iron deficiency, actually it is the hemoglobin level, the simplest thing to note down. And anemia is a condition we all know where this hemoglobin is low. So what is a normal level and what is a mild and moderate and severe anemia? It depends depending on the hemoglobin level. And RBC actually they are the carrier of the hemoglobin, and which is a carrier of the oxygen. So basically we all, if we are low in hemoglobin, we are low in oxygen. So we are basically hampering everything and growth. So normal level is around 12 in a woman. So that is a very something simple to remember, 12, 12. And this mild anemia start when it is less than 10, and it is moderate when it is at 8 to 10 around, and severe is a less than 8. So next slide, please. So, and the classification of anemia is again, there's two types of anemia, basically mainly, and depending on the cause and on depending on the morphological status of the RBCs. So on the cause, there's a blood loss is there, whether it is acute or chronic, and it is causing the iron deficiency and anemia. And inadequate production of normal blood cells that leading to almost that factory output, that is a bone marrow. So there is a defect over there, and or if there is an excessive destruction of the blood cells like hemolytic and this morphologically normocytic, microcytic, and depending on the size, whatever is visible there at the that MCB. So the next slide, please. So this anemia is the hemoglobin when it is macrocytic, it is MCB is actually when it is less than 80, and normocytic is 80 to 100, and macrocytic is this thing more than 100. There is a one thing when we should need to remember is when we are diagnosing or we are managing anemia is transferrin saturation. So if it is a transferrin saturation is actually normally it is 20 to 40% is there, and micro in level, and it is in microgram. It is this can detect the iron overload if we know the transferrin situation. And there are this serum ferritin level and all in this etiology, and use this chart is very important to remember, because this thing is macrocytic one is very common. We must know that serum sometimes we keep on just giving iron to the patient, and the patient are not responding. At that time we need to know that whether it is a B complex deficiency or not. And MMA is that sometimes we test, normally clinically we don't test, but because the values are 0.2 0.4 millimole per ml, and so MMA is a methyl malonic acid. So if it is high, so that shows that there is a low B complex level. So this vitamin B deficiency, and in vitamin deficiency, this level is increased. So if we look at instead of only hemoglobin, if we look at the other things also, so that will help us. In rural and areas and urban areas, we know it is a very sad to know that it is still rising, and it is around 58% of the anemia, all 60 or 70 you can say, in children's and the pregnant women. And in urban also, then again the causes are the 30% of the boys also suffer, and our women are also suffer, and this causes leads to much of the physical and the mental development deterioration. Next slide, please. So because unless for the well-being of the woman, so we have to know that because iron is a basic molecule which gives strength, because iron as such is making a person strong. So it is the most, this iron deficiency anemia, commonly known as IDA, and these are the symptoms whenever the patient is complaining of this, all these symptoms, that it is enough iron is not there, so to maintain the various health of the and patient feels weakness, dizziness, and we should take care of that. Not only that, when we say that this, she is a psychological only. Next slide, please. And this iron deficiency anemia is a global issue. And India has the highest prevalence of anemia in the world. We can see by this chart. Next slide, please. And this absolute and functional deficiency anemia is actually, there's a demand of iron is increased. Anemia is mainly because of the four important causes. The demand of the iron is increased and it is not being supplied, and intake is increased, and increased intake, or there is an increased loss. So the intake is decreased when they are not getting taking iron or iron rich foods. So this is the increased iron demand. All this chapter, this slide is also showing very nicely. And then there is a, you can see in this inflammation also causes this GI inflammation, also causes, and so many chronic illnesses which lead to there's a hormone called hepcidin. So this hepcidin actually is a main thing which helps in getting the iron into the circulation from the intestine. So if it is low because of the inflammation and because in the chronic illnesses, so this also causes the iron deficiency anemia. Next slide, please. So in spite of everything, all efforts, India is trying hard to make our women less anemic and our children's more with the more hemoglobin, but still, and we are trying to keep the balance. Still, all the surveys, they are saying that children's aged below 5 years, they mainly depend on their mother for iron need, and they are neglected. And even this preconceptional counseling has also been a very important thing, because once right from the birth, their iron stores are low, and so later on, when the children adolescent, it passes the low iron stores are passed to the adolescent and again to the next years and reproductive years also. So that's why the woman suffers a lot. So if we take care of the children's and our adolescent, we will be much better. Next slide, please. So anemia is actually the largest spike is seen in the Indian children's who are 6 to 59 of months. And this is a recent national family survey which is covering 6.5 lakh sample household, and it was detected and it was seen that iron deficiency anemia in pregnancy is also responsible for this low anemia, low hemoglobin in children. Next, please. So if we, next slide, please. So if we know anemia in global issue, so we, as a mind-boggling puzzle is that why such high prevalence is still in India, because in spite of all the efforts, we are still having, maybe there are certain things which must keep in mind, that there are actually the poor eating habits and early onset of the childbearing and high parity and short interpregnancy interval, long lactational period, and not taking diet properly. And hookworm infestation and malaria is one of the very, very common in India. And the lack of access to health care was again noted. And so that is why the training of the paramedical staff, so that even we can, each and every person of India can get this health care is the main motto. Next, please. So as the name implies, the WHO, they say in first trimester, second trimester, and third trimester, they say they maintain the hemoglobin. And if it is found to be less, then you please diagnose it as an anemia and start managing accordingly. Next slide, please. And even the ICMR also, the Indian Council of Medical Research, they also say that normal hemoglobin range is above 11. It should be maintained. Next, please. And so these are very, very important. Even the Center for Disease Control also say that even the tested hemoglobin should be tested in all the trimester to track the anemia, because unless and until we know who are the patient who need iron treatment and what type of iron treatment, then this clinical data will help us a lot. Next slide, please. So outcome, this is a what effects this anemia can have on pregnancies, mainly on the woman health also is there. So maternal morbidity and mortality is increased because of the and so much of reduced work capacity, and patient they whatever cause if the back of the problem anemia is there, then it is 10 times fold problem and risk is increased. And this low hemoglobin or low oxygen level of the body, it affects the immune functions also and increases the risk of infections also. So if the risk of infection is also there, then the fetus is also likely to be affected, and they are mainly low birth weight babies, and they are anemic, or the chances of stillbirth are also more, and then there's neonatal deaths are also found to be more, and the pregnancy outcome also, including all sort of risk which we know can happen, especially the preterm delivery, and if the patient is going into the labor, then suffering is more if the patient is anemic, and even 50 ml of the blood loss in those patients, they cause havoc. So next slide, please. If this study also say clearly say that the pregnant woman with anemia twice as like, I must say that they're 10 times more at risk to die or shortly after the pregnancy, because anemia is a one thing which make them more prone to each and every complication, and this properly and timely management of IDA is very, very important. Next slide, please. This pregnant women are more at risk, and that is a factor with, if we take care right from there, then the first stage of the adulthood is start from there inside the in utero, then it will be very. So these factors are backs had the highest prevalence. We all know that 3 times more common in Africans and then this thing in pregnant women, and this taking the diet which are poor in iron rich sources, then this is also one of the important things. Next slide, please. And so very something we all talk about anemia. So how many of us know that if other than hemoglobin, what are the things which we can manage, and how to screen the patient, and how to again watch them whether they are doing or not. So this simple history taking and examination and investigation. So history is we all know all the menstrual history and heavy menstrual history and all the personal whether she's having breathlessness and work and what is work capacity and all, and examination also, and then comes the investigation. So this next slide. So screening recommendations are obviously so many guidelines, so many protocols to take care of this. So this recommendation are there. So this CDC recommends actually universal screening for iron deficiency anemia and supplementation of the iron tablets to all. So the basic 4 thing is this: how to talk about anemia, and then treat the anemia, and then diagnose the anemia, and then trace also. If we are not just giving them, counseling them, once if we know they are anemic, so how many days we should take care of. So iron deficiency anemia with CBC at least should be done twice in the during antenatal, and preferably in all the trimesters. And this the most important thing now to remember is the RBC indices, serum iron levels, and ferritin other than the hemoglobin. And though even if we are not able to do anything, this thing, empirical treatment with iron is allowed and reasonable. And this we can expect the reticulocytosis within 7 to 10 days. And so if we give the iron, we should always retest after 4 weeks. Next. This hemoglobin testing actually can be done both direct or indirect also, by the indirect by the capillary method and direct by the venous method, and CBC the PCV. So now there's all those HemoQ type of things which we can do within seconds. It tells the PCV hematocrit also. Majority I have sometimes I ask the pupil, and they are confused what is hematocrit and what is a PCV. So that is also something we doing this. And when is the just shift to the hematological to the bone marrow. So the 5 things are very, very important for diagnosis of anemia. Number 1 is a hemoglobin estimation. Number 2 is a ferritin level. And number 3 is a serum iron. And then total iron binding capacity and the low transferrin, transferrin saturation, which I talked in the earlier. So in this anemia, actually this hemoglobin is low, and there's a low level of ferritin, low serum iron, and but iron, this total iron binding capacity is increased. So all the 4 are low, but this TIBC is increased. So that shows because the patient has the chances of uptake of iron when you give is more and rapid. So that is why. The next, please. So the management of this iron deficiency anemia is again dependent on the 5 things: medical nutrition therapy, then deworming. This is social health programs also, and in the medical other than the medical nutrition, then the this iron therapy. Iron therapy can be done in the oral or the parenteral iron, and the severe and extreme cases, the blood transfusion is recommended. Severity of anemia and what is the gestational age of the patient. And medical nutrition is, this diet is something very, very important. So we must remember, if there are phytates, so many people are so diet conscious, they are asked what are the things which hamper the iron intake or absorption. So one thing is iron, tea, coffee, and all this thing they hamper. Obviously, if you take along with the coffee or tea, they reduces this. And nuts and seeds, they have phytates. So the phytates, they also again they cause the problem. And if you do the simple things is like sprouting. So sprouting, this helps to destroy the phytates. It not only changes the taste, it helps in it's helpful also. And this somehow baking and this soaking before making the sprouts and dals and nuts, especially badam also, jaise bhigo ke khate hain, so that is also helping a lot. And this and consumption of iron rich foods is told to them, so that, and they cook in the iron utensils also, and intake of iron supplements in between meals is also supplied. It is also tell them. Next, please. And deworming is as a health measure is something very, very important, and we have to aware all. We have to tell them the sanitization importance and the malaria care also. And this routine deworming is recommended by WHO in the after the first trimester. And this dose is albendazole single or mebendazole single as a 500 or BD for 3 days. Next slide, please. So Anemia Mukt Bharat is India getting freedom from issues and making our a woman very healthy. So this oral iron therapy is the first line treatment. Ideally, we should start with the oral iron treatment, though only 1 to 8 absorbed, and absorption increases with the when you increase the dose, but the side effects are also increased. And this next slide, please. So in all the mild cases, all even moderate cases, one can give the iron salt. So the basic question again, which salt to give, what is the best and what is not good, what is acceptable, what is not. So if we know that there are 5 classes of iron salts: inorganic, organic, elemental, chelated, and iron, and this technological. So inorganic is the most importantly used, and organic is a polymaltose, and that is inorganic is the easily available. And there's 2 types of this ferrous sulfate and ferrous fumarate, ferrous ammonium sulfate, ferrous gluconate, for ferrous succinate. Next slide, please. They all have elemental iron is different in this different fumarate or sulfate. This elemental iron is presence of elemental iron is different in all these things. So the general instruction for when the patient start is taking tablets on empty stomach. This is very, very important, and giving them vitamin C is again very important. And just avoid tea, coffee, milk, or calcium tablet along with it. We should remember to write on the prescription also. And then next slide, please. Peptose. affecting oral iron absorption. So this is a beautiful slide which is showing that status of the patient iron stores is very, very important, and what dose you are giving and the bioavailability of, because of the presence of the element, what kind of elemental and how much elemental iron is there, and there's a gastric acid features. So that is again, next slide please. These are the so iron preparation, you see, ferrous fumarate is the best cost effective, most commonly used, and ferrous glycinate is more effective and better tolerated than this thing, any ferrous sulfate. And ferrous ascorbate, we are again most effective and better tolerated, high bioavailability up to the 40%. And tablet is there, so 65 milligram of elemental iron is there, and ferrous fumarate 106 elemental iron is there in 325 milligram of tablet, and ferrous gluconate 4 milligram only elemental iron. So, and carbonyl iron is again a very good, and it is tolerable with less side effects. Next slide, please. So these are again, next slide, please. So how much to give is again very important. These are the guidelines, WHO and Ministry of Health, Government of India. The Government of India say that daily 100 milligram of elemental iron plus 500 milligram of folic acid for 100 days, starting after the first trimester, that at 14 to 16 weeks of gestation, and to just in the mild anemia, 2 tablets per day for 100 days. And moderate anemia, this start jump off to the injectable iron, and then postpartum of again for the 6 months. So again, you have to test the patient and during pregnancy, and continued for the postpartum for again more 6 months. Please. So repeat next slide, please. Repeat hemoglobin is tested in between. So to take the next, please. So this response is something very, very important. Response to your iron therapy. So if we just response can be very evident if by number one, just by the asking the patient the sense of fetal well-being, sense of well-being. If the patient is feeling better, that means your tablets are working and the patient is getting better. And there's an improved outlook also. So patient it was lethargic and all, and when he's taking the, you may not test, and you just can rely on that also. And then most importantly is a rise of the hemoglobin, which is normally generally 0.5 to 0.7 gram per week. It is seen if the patient is really a case of iron deficiency anemia, and you are treating that, giving the iron tablet. So, and this hemoglobin levels are increasing. So response is seen in that way. Next, please. The challenges, what are the challenges when you are giving that iron tablets? Generally, it is the patient psychology also, that they go by the color, they go by the taste also, and then the most importantly is a side effect. हमको normal खाना खाने का मन नहीं कर रहा है, हम iron tablet कैसे खाएंगे? And they always think if we take iron tablet, and my baby can be a black one. So they want to eat more of a nariyal and white nariyal, and then the iron tablet. So we have to tell them that this is something very, very important. And now even the government has taken this point very nicely, because previously the iron tablets were black in color, and now they are red. So that is again this challenges. So poor absorption and non-adherence. Non-adherence is again very, very important. And here the treatment failures, and they don't come, take the tablet, they don't come for the investigation. So for those again, so that is a case that you have to be very sure that they are taking the tablet, because the medicos can only write, but you have to follow up. So the follow-up is very, very important. Now, if you can think that switching off to parenteral iron is very easy, but again the patient, they don't like that, and they also want to avoid that also. They don't want injectable also. But so somehow it is, if we tell them that take empty stomach, because a little bit of counseling is needed. So next, please. So to summarize and this, because iron deficiency anemia is so common, almost every second patient, rather I must say every patient should be taken as a case of iron deficiency anemia, and oral iron supplementation should be started even if patient you are not testing, but try to test the patient. Test first we like in awareness program nowadays, we are telling first test yourself and then test all your known people, and then keep on testing. Tell the patient the value of hemoglobin testing. They will always go, and gastrointestinal side effect, take care of them, and suboptimal patient adherence can be managed if you are telling them politely that बच्चे को तो बड़े होके इतना strong बनना है, बच्चे को तो top करना है. India wants the bright and brilliant children, so that responsibility is on the mother and on the parents, and so the tablet is there. So parental iron is again a very nice option, but oral iron tablets are really something everybody look for them. Thank you very much.
Thank you so much, Dr. Archana ma'am. It was, I think, an excellent deliberation that you gave us, and you took us into a real depth into anemia. And the important thing I think that you highlighted was the diet. We really have to go. Mandakini ma'am, you're there?
No, you please continue.
So, ma'am,
yeah, because I thought madam is to leave, so.
No, I'm there.
मैं बोलेंगी तो better रहेगा मेरे लिए तो अच्छे से. Yes, madam, diagnosis of iron.
You stressed very well. I think diet, we really need to ask them what they eat. And sometimes they don't even take the proper meals. And the second thing you said, and obese patients, they think that if we cut down diet, we'll be slimming down, but that's not actually the fact. They need to take the diet on time, and that's why even they may go anemic. And the other concept is that I'm taking a very good diet. Why don't I need to take any tablets? But you stressed very well that the requirement is 27 milligrams in pregnancy and 15 milligrams in lactation, and 9 milligrams. And our diet is really deficient. It doesn't give the required amount. It gives only 15 milligrams. And the deworming is very important. And I think you stressed a lot. You do the every trimester hemoglobin estimation. That is, you have the cutoff limits. And I think if we follow those, we can just catch them at a very, very early point. And the point of confusion, which I think stands with every one of us, which oral iron to pick up. And it's a fumarate, it's ascorbate. And so I think the bioavailability stands as the first factor, the 40% bioavailability with the ascorbate. And the rapid absorption too. So thank you so much, Dr. Archana, for that.
Thank you very much. Excellent deliberation. Very basic subject, but it is very close to our heart. Foxy president, all the president, in the president of India, even the prime minister, we are after the eradication of anemia. That is our topmost agenda of health budget also, health priority also, because it leads to so many complications. So I think well summed up, Ritu. And I acknowledge the presence of our guest of honor, Dr. Ame. So good afternoon. And
so to formally introduce our guest of honor, thank you very much, Dr. Ame Purandare sir, for being here. Sir is currently the Vice President of AMOGS. He's also served as the Joint Secretary of FOXI in the past. He's been chairperson for the FOXI Food, Drug, Medical, Legal, Surgical Equipment Committee in the past. He is also currently the Assistant Administrator of Manyata, a peer reviewer of the Journal of OBGYN, and somebody who has led the way not only in thoughts but also in deeds for all of us in FOXI, in AMOGS, as well as the Mumbai Society, following in his footsteps. Can we have a few pearls of wisdom from you, sir?
Yeah,
now you can stop sharing.
Thank you, Pratik, for those kind words. I think the biggest introduction is that to receive good words from you and all our other friends and colleagues and seniors who are there today. I think, first of all, let me bring you greetings from AMOGS, and let me wish all those present as faculty, as chair, and most importantly, our delegate friends who have joined in Public Day. We have already achieved 75 years of independence. We are celebrating Azadi Ke Amrut Mahotsav, but I think the generation has moved on. We saw the freedom fighters. We've heard their tales of how they fought for freedom and gave us this good life in a free India, in a Republic India. It is now for us, the present generation, to take this legacy forward and cause growth and development of India. Most important, to ensure that the health and well-being of our population is compromised. Last but not the least, we must remember is that it is our responsibility as healthcare professionals that we ensure that public health is always maintained. Therefore, eradication of anemia, I think, is an absolute paramount priority as far as the health of women is concerned. Because if it is a healthy woman, it will be an empowered woman. It will be a strong woman, and this will ensure that there is a strong community. Pratik, I think it is very apt that you have started today's seminar or webinar, as it is called, with anemia. As you remember that each one of us here today is closely associated with it. I see our respected Dr. P.K. Shah, one of the past presidents of FOXI, who very emphatically launched the anemia prevention program during his presidency. I think he was very passionate. He told us that if we work hard, one day he dreamt that it will be eradicated. Dr. Nandita Palshetkar, past president of FOXI and past president of AMOX, launched the No Anemia campaign, and I think all of us contributed to it during her presidency, both in FOXI as well as in AMOX. Dr. Mandakini Meg, past chairperson of ICOG, launched the Anemia Mukta educational series, where each woman healthcare provider understood the importance of anemia, its aggressive diagnosis and aggressive treatment. Dr. Archana Verma led the way as far as public awareness is concerned with her passionate work as public awareness chairperson, and now as and then as vice president, ensuring that the message of anemia prevention, eradication reach the masses so that they could comply with it. And my dear friend, Dr. Ritu Khanna, who is at present the Food and Drugs Committee chair, I hope that Ritu will work very hard to ensure that we soon have fortified foodstuff with iron. We have succeeded with iodine. We are succeeding with folic acid. And I think very soon our food will also be fortified with iron. Again, once again, I bring you the best wishes from AMOX. Pratik, congratulations on your good work. And I hope that these educational webinars continue so that everybody, not just at AMOX, but all over India, are benefited with it. More importantly, they translate this benefit to better management of the patients. Thank you.
Thank you very much, sir, for making it despite your busy schedule on Republic Day. I know you have several occasions to go to, several events to grace today. So thank you very much for taking time out from your busy schedule. I'm proud to announce that we have an audience in excess of 1,000 people all over the country and also from abroad who are watching this fantastic program. And without further ado, without keeping our star speaker waiting, I would request Dr. Ritu to please introduce Dr. P.K. Shah, our past president of FOXI. Sana, can we have the slide, please?
In between, I must say, Dr. Ame,
Thank you so much. Yeah. Thank you so much, Dr. Amya. And we are going ahead. Dr. Amya has joined hands with me for the food fortification program. Thank you so much for that initiative, Dr. Amya. And my regards to Dr. P.K. Shah, sir, Dr. Sujata Dalvi, madam, and also Dr. Rajendra Singh Padesi. And thank you, Dr. Pratik, for having us here, and Mandakini Mag for being with us here. So moving forward, it's an honor and a privilege to introduce a stalwart, a great teacher, a mentor, and I know he's so inspiring and so innovative, and that's Dr. P.K. Shah, sir. He is a professor, unit head, Department of Obstetrics and Gynecology, State, GS Medical College and KM Hospital, Parel, Mumbai. He has the past dean, Indian College of Medical Ultrasound. He has been past president of so many associations, Indian Association of Gynecological Endoscopists, Federation of Obstetrics and Gynecology of India, Indian Federation of Ultrasound and Medicine and Biology, Mumbai Obstetric and Gynec Society, Association of Full-Time time teachers KEM Hospital. And he has been the Foxy representative to a FOG 2010 to 13. He's been the past editor, OBGYN Journal Today, and a member of Safe Motherhood Committee. So many honors and awards and lots of publication. They're innumerable. And it's always a pleasure, sir, to have you amongst us and also to hear you. So over to you, Dr. P.K. Shah, sir.
Thank you so much, Dr. Ritu, for your kind introduction. At the outset, let me thank the office bearers of AMOGS. That is Dr. Rajendra Singh Pardesi, President of AMOGS. He was resident in our unit when I was lecturer. And now he has become the president of huge association called AMOGS. Dr. Sujata Dalvi, a very close friend from KEM Hospital, who is the secretary. Then Dr. Lakshmi Shikande, who was a vice president when I was the president of Foxy. Now she is the chair of Indian College of Obstetrics and Gynecology. And Dr. Ashok Kumar, who is the secretary. Above all, I think I must thank Dr. Pratik Tambe, who remembers me time and again for some odd lectures. He wanted me to talk on one of the subjects last week, but we were at Andaman and I could not accept it. So he gave me this nice topic, that is parenteral I3. It is not 13, but parenteral I3, a game changer. What is this I3? Intravenous iron. That is, now this is a new molecule which is available to all of us in the market.
Sir, sorry to interrupt. We need you full screen, please.
Sorry?
Sir, the slide is not seen full screen.
Oh, it is not seen.
Yes, sir.
One sec. So I will stop sharing.
Yes, sir.
I'll share it again, as you said. Now?
Yes, sir. Perfect. Go ahead, sir.
Okay. So why do we need these changes? As the technology advances, a lot of work is being done in the field of obstetrics and gynecology. And they start improving the molecules that we've been using. And now we have got a molecule which is supposed to be the best as far as intravenous, that is parenteral iron, is concerned. I still remember we used to give iron sucrose. When it came, we used it so much. Then came ferric carboxymaltose, FCM. Again, we used it in our practice. And now this is a third molecule which has come, which may change the whole practice of obstetricians and gynecologists, as I feel. I don't know why it is not moving. Sorry, it's not moving.
So if you can just click your mouse once and then use the arrow key. Yeah, perfect.
Okay. Now, Dr. Archana Verma did my job easier. She has covered iron deficiency anemia in detail, and she has told us the use of oral iron. Just few slides, couple of slides to tell you what are the indications for parenteral iron therapy. We all know poor tolerance to oral iron, poor absorption, non-compliant patient, women with moderate to severe anemia near term, women on recombinant erythropoietin. All these patients need parenteral iron. But there are some contraindications, like history of anaphylactic reactions, need rapid restoration of iron stores, and if she has any active infection in the body. What happens when you give parenteral iron? That you give more iron in less time. When you give parenteral iron, you should stop oral iron at least 24 hours before you start the parenteral iron. And you can start or restart the oral iron 1 week after completion of the last dose of parenteral iron. Now, what are the prerequisites for parenteral iron therapy? That you must confirm the diagnosis of iron deficiency anemia. Dr. Archana covered it so beautifully well. And you must know that it has to be iron deficiency anemia when you're trying to treat the patient with parenteral iron. You must take adequate supervision, and you should have all the management of anaphylactic reaction in case she gets it. Do sensitivity tests prior to infusion, and it is recommended by even Government of India wherever needed. To again tell you contraindications to parenteral iron, issue of anaphylactic reactions to parenteral iron therapy in past, first trimester of pregnancy, try and avoid intravenous iron or intramuscular iron, chronic liver disease, active infection, no evidence on the use of IV iron in the first trimester of pregnancy is present at present. Oral iron should be stopped at least 24 hours before giving the parenteral iron. Now, this is something very basic that everybody knows. How do you calculate the dose of parenteral iron? Just to repeat it for you, required iron dose in milligram is 2.4 multiplied by what is the targeted hemoglobin and what is the actual hemoglobin now. So if you want 11 or 12 grams, and if it is now 7, you deduct, and that is what you multiply with 2.4 and multiply that with pre-pregnancy weight in kg. Please remember this very clearly. Now, previously, we used to give, when we were residents, 500 milligram for replenishment of stores. Now, it is advocated that you must give 1000 milligram additional for replenishment of stores. So the target hemoglobin is 12 and the actual hemoglobin is 7, so that comes to 5. Pre-pregnancy weight is suppose 60 kg, so 5 into 60 is 300. 300 multiplied by 2.4 is 720. That is 720 milligram plus 1000 milligram. So the total comes to 1720 milligram. Now, you have 3 generations of parenteral iron therapy. Ferric hydroxide and iron dextran. We used to give long back. It came second generation, iron sucrose, ferric gluconate. Sorry. And now, the third generation, iron isomaltoside, that is a iron I3, iron intravenous iron isomaltoside. FCM we all know, and ferrium oxidol, which not many of us have used. How do you classify it? Depending on the type of complex, that you can call it a strong complex, type 1, and that includes ferric carboxymaltose, iron isomaltoside, which is a molecule I'm going to talk to you about in detail, and dextran, moderately strong iron sucrose, that is type 2, and type 3 is weak, which is ferric gluconate and ferric hydroxide, which you don't use in our practice. Now, coming to intramuscular preparations. We all know that intramuscular preparations are slightly better than oral iron, though we were told when we were students that the rise in hemoglobin is the same whether you give oral iron or parenteral iron. This includes iron sorbitol citric acid complex, iron dextran, and iron polymaltose. The Ministry of Health and Family Welfare, Government of India recommend intramuscular iron following a test dose as treatment of choice for moderate anemia in pregnancy. What are the drawbacks of intramuscular iron? Inconvenience of painful injections, dark discoloration of the skin, and various side effects, including chances of abscess formation at the site of injection. Now, how do you manage this mild to moderate anemia and severe iron deficiency anemia? And if you have a hemoglobin which is more than 10 grams per deciliter but less than 12, ferritin is less than 100 nanogram per milliliter, transferrin saturation less than 20%, total iron dose required is about 1300 to 1800 grams. Start oral iron if it is mild, 100 milligram per day. 4 to 6 weeks, hemoglobin increase should be at least more than 2 grams per deciliter. If this happens, continue with the oral iron. But if it rise in hemoglobin is not more than 2 grams per deciliter in 4 to 6 weeks time, then you have to go for either intravenous or intramuscular iron. And that includes iron sucrose, almost 7 to 9 times. You have to give 100 to 200 milligram. Ferric carboxymaltose, 2 doses, and iron isomaltoside, 1 to 2 doses, depending on what is the requirement. If it's a severe iron deficiency anemia, that means hemoglobin less than 10, ferritin less than 100, transferrin saturation less than 20, the requirement more than 2000 milligram. You have to give either iron sucrose more than 10 doses, FCM more than 2 doses, but iron isomaltoside 1000 milligram or low molecular weight 1 to 2 doses, even up to 2000 milligram calculated by weight of the patient, that means less than 20 milligram per kg body weight. If the hemoglobin rise is more than 2 grams per deciliter in 4 to 6 weeks, monitor periodically and continue to monitor this patient till she delivers. Now, there is something which we all know about. The iron dextran contains the carbohydrate in the form of low molecular weight dextran. Ferric gluconate contains gluconate, iron sucrose contains sucrose, ferric carboxymaltose has carboxymaltose, whereas the molecule I'm going to talk about, iron isomaltoside, has isomaltoside as carbohydrate. What is the importance of this carbohydrate shell in parental iron? Every parental iron is complex with carbohydrate moiety, which holds the iron till the iron complex reaches the liver or spleen. Stronger the complex, safer is the parental iron because it will release less labile ions. What is this labile iron and how they are harmful? Labile irons are free irons released from the iron complex after administration. Since these are irons, they are responsible for effects like hypotension during intravenous infusion, hypersensitive reaction, oxidative stress, and cytotoxicity, etc. So labile iron potentially is least with iron I3 isomaltoside. Why iron I3 isomaltoside has low labile iron potential? So iron isomaltoside consists of iron and carbohydrate moiety, wherein iron is tightly bound in a matrix structure. This enables a controlled and slow release of iron to iron binding proteins, avoiding potential toxicity from release of labile iron. Now, as you can see from this graph, compared to ferric carboxymaltose and iron sucrose, the iron I3 isomaltoside has the lowest of labile iron. Now, when you try and compare the 3 commonly used parental iron available now to us, like iron sucrose, ferric carboxymaltose, FCM, and iron 3 isomaltoside, Iron sucrose is second generation, whereas FCM and iron I3, the third generation. So carbohydrate ligand is the sucrose, carboxymaltose, and isomaltoside. Average sitting required is 7 to 9 for iron sucrose, more than 2 for FCM, and 1 to 2 for iron isomaltoside. Maximum single dose that you can give is 200 milligram with iron sucrose, 1000 milligram for FCM, and 1500 milligram with I3. Minimum administration time in minutes, 30 minutes for sucrose, FCM 15, and I3 15 minutes. Test dose is not required for FCM and iron isomaltoside. So what is iron isomaltoside? This I3, which is mentioned into bracket, is intravenous iron isomaltoside. It's the only intravenous iron preparation with no upper limit of intravenous iron administration dose. Iron isomaltoside 1000 is a third generation IV iron compound introduced in Europe in 2010. DCGI approval was given in 2013 and approved by US FDA in January 2020. So what is the mechanism of action? So when you give this parental iron isomaltoside, it is absorbed by the reticuloendothelial cells of liver and spleen. It splits the iron complex in liver, and iron binds to protein and forms ferritin and replenishes the iron store. Now, when you try and compare this new molecule with already existing molecules which we have already used in our practice, how does it compare? So we have almost last 5 or 6 years of presentations in international journals as regards this molecule. So single infusion iron isomaltoside versus multiple infusions of iron sucrose in Blood Volume 2018 journal. 1,512 patients with IDA, of whom 26% had GI and 50% plus anti-gynecologic blood loss. When iron isomaltoside was given, 1000 milligram infused over 20 minutes at baseline, all of them required only one visit, whereas iron sucrose required 4 to 5 visits. The primary endpoints were educated, serious or severe hypersensitivity evaluated, and responders who had hemoglobin rise of 2 grams per deciliter. So what was seen when you had a single dose I3, hemoglobin increase from baseline after 1 week was 0.7, and after 2 weeks was 1.48 for I3, and it was less for iron sucrose. And proportion of responders with hemoglobin increase more than 2 grams per deciliter was almost 32% compared to 20.8% for iron sucrose. So percentage of patients with increase in hemoglobin more than 2 grams per deciliter with I3 was 68%, and with iron sucrose around 51%. Number of administrations required was 1 to 2 for isomaltoside and 5 to 9 with iron sucrose. And medium time for hemoglobin increase more than 2 grams per deciliter was 26 days for isomaltoside, whereas it was 37 days for iron sucrose. What is the superiority of I3 iron isomaltoside? That the latest generation IV iron with more stable iron carbohydrate complex, iron isomaltoside has less potential of Leber iron generation. Iron isomaltoside does not require test dose, unlike iron sucrose, and iron sucrose can be given a maximum 200 milligram, not more than 3 times per week. And doses must be at least minimum 24 hours apart, while iron isomaltoside can be given for more than 1000 milligram in a single visit, up to 1500 milligrams. Faster and higher hemoglobin rise was found with iron 3 isomaltoside compared to iron sucrose. Now, one more thing that we use in our practice is the ferric carboxymaltose, the FCM. So they compared the use of I3 with FCM. There was higher risk of hypophosphatemia with ferric carboxymaltose. FCM, even in one sitting, causes raised fibroblast growth factor, which leads to reduced phosphorus level, reduced vitamin D level, reduced calcium absorption, and all these will lead to hypophosphatemia. I will not go into details of this, how this hypophosphatemia occurs, but this is how more and more phosphate is excreted in the urine. There is increased parathyroid hormone, and there is a less of 1.25 OH2D, etc. And it has been shown that higher risk of hypophosphatemia with FCM compared to iron sucrose. So significantly more pronounced drop in plasma phosphate from baseline observed in patients receiving FCM than iron isomaltoside. Now, there is a good paper in JAMA in 2020 and the previous one in JAMA 2019. And it showed that there are 10 times higher incidence of hypophosphatemia with ferric carboxymaltose. Almost 10 times, 7.9 times with iron isomaltoside, whereas it was almost 75%. And the same thing was found earlier in the previous trial also. When they tried to study the same thing with iron isomaltoside, they found no changes in vitamin D and calcium hemostasis with iron isomaltoside. Serious or severe hypersensitivity reaction occurred in 0.8% in I3 group as compared to 1.7 in FCM group, and FCM induced changes in vitamin D and calcium hemostasis that triggered secondary hyperparathyroidism, which likely contributed to persistence of hypophosphatemia. FCM also induced significant elevation of biomarkers of bone turnover that are associated with osteomalacia. Patient level cost effectiveness analysis of iron isomaltoside versus ferric carboxymaltose for the treatment of iron deficiency anemia was carried out in UK, and this was published in 2020 in Journal of Medical Economics. And what they found, that the baseline hemoglobin was same for both the groups, FCM as well as isomaltoside. Change from baseline hemoglobin 2.49 for FCM and 2.74 for I3. Proportion of patients responding around 70% for FCM and almost 80% for iron isomaltoside. Hemoglobin after treatment was 12.53 for FCM and 12.78 for isomaltoside. Iron infusions required per patient 1.9 times and 1.38 times. And total cost of infusions in Great Britain pounds 637 for FCM, whereas it was 458, and cost per responder 910 Great Britain pound and 579 for iron isomaltose. The cost of each vial of 500 milligram of isomaltoside, the I3, is around 1700, whereas the same for FCM is around 3,400. That is the reason this difference was found in indirect comparison. So what was the conclusion of this indirect comparison? They found that patient level cost effectiveness analysis of iron isomaltoside versus ferric carboxymaltose treatment of iron deficiency anemia in UK. The analysis showed that using iron I3 isomaltoside rather than FCM in patients with IDA was dominant and would reduce the number of iron infusions required to correct iron deficiency, thereby reducing the associated cost with the treatment and simultaneously increasing the proportion of patients with IDA experiencing a clinically meaningful hematological response. So how is iron isomaltoside superior to ferric carboxymaltose? Iron isomaltoside is tightly bound and shows very low concentration of free iron, and free iron concentration in FCM is significantly higher, as you can see in this graph on the left side. When they compared FCM with iron isomaltoside and iron deficiency correction in a single visit, obviously iron isomaltoside is the single IV iron injection that can be given more than 1000 milligram in single visit. FCM can be administered in dose of 20 milligram per kg, to maximum of 1000 milligram per infusion, whereas isomaltoside can be administered in high doses of more than 1500 milligram with a maximum dose of 20 milligram per kg within 30 to 60 minutes. Now, it is not that ICM is given only in OB/GYN. It is also being used in oncology, chronic renal diseases, cardiology, inflammatory bowel diseases, gastroenterology, and for perioperative care. Now, whether can you give this I3 during pregnancy? The answer is yes. The parental ions in pregnancy categories are iron isomaltoside, iron sucrose, and ferric carboxymaltose. All come in pregnancy category B. Higher doses of 1500 milligram is safe in pregnancy, as shown in this particular paper, which was an expert hematological review in 2020 Feb paper, and it showed that 21 prospective trials, including over 8,000 patients receiving iron isomaltoside FCM or iron sucrose, were retrieved and observed for hypersensitivity reactions. The risk of severe or serious hypersensitivity reaction was lower with iron isomaltoside relatively compared to FCM and iron sucrose. There is one more paper which is in International Journal of Transfusion Medicine in 2017, whereby 213 pregnant women from the beginning of the second trimester until a few days before delivery each received single administration of 1000 or 1500 IV iron isomaltoside, and they were observed for adverse effects. And what is the conclusion of this paper? That these results support the convenience, safety, and efficacy of a single high dose up to 1500 milligram infusion of iron isomaltoside for iron deficiency or iron deficiency anemia during pregnancy. And then negligible patients reported mild adverse drug reactions. Now, can it be used after delivery? Again, the answer is yes. And this is all evidence-based medicine that I'm talking about, that iron isomaltose postpartum period fatigue. It was published in Journal of Maternal, Fetal and Neonatal Medicine 2019. IV isomaltoside treatment of women suffering from severe fatigue after postpartum hemorrhage. Dr. Archana Verma told you one of the symptoms of iron deficiency anemia is fatigue. That was the first thing that she showed. And this particular aspect was picked up, and they showed that iron isomaltoside 1200 milligram diluted in 100 milliliter of 0.9% sodium chloride given over at least 15 minutes compared with oral current treatment practice with oral iron. What they found in this particular paper, that a single dose of I3 is associated with a significant, statistically significant and clinically reduction in aggregated fatigue within 12 weeks after delivery. Again, one more paper in International Journal of Transfusion Medicine in 2017 for postpartum fatigue. The conclusion was that a single dose iron isomaltoside was associated with a statistically significant reduction in aggregated physical fatigue within 12 weeks after postpartum hemorrhage compared to oral iron. A patient reported outcomes improved significantly, and intravenous iron resulted in a fast hemopoietic response without serious adverse reactions. I3 may be useful alternative after PPH if oral iron is not absorbed or tolerated, which is a very common scenario in country like ours. One more paper on I3 in International Journal of Obstetrics and Gynecology 2015, which compared iron isomaltoside in increasing iron content in maternal milk. So iron content in maternal milk from mothers treated with a high single dose of infusion of iron isomaltoside 1000 milligram. There are 65 healthy women with a singleton delivery and postpartum hemorrhage. What they found, iron content in milk 3 days after intervention, the iron isomaltoside group was around 72 plus minus 27, whereas in oral iron it was 39.99 plus minus 17. So the conclusion of this paper was treatment with higher dose iron isomaltoside 1000 milligram resulted in 2 times higher iron content in maternal milk. Then postpartum anemia. And this paper again by Fox Sang in 2017 concluded that the study showed that intravenous iron could be an alternative, right? Attractive alternative to RBC transfusion in severe postpartum anemia. So when you compare blood transfusion and I3, I think this is a good paper that you can look at. Now, coming to last part of my talk, that is a dose calculation and administration. You must find out the determination of iron need. The iron need can be determined using simplified table or the Ganzoni's formula. This is what we have to follow, the Ganzoni's formula. It is expressed in milligram of elemental iron. What is a simplified table? It says that if the hemoglobin is more than 10 milligrams per cent, but less than 12, patient's body weight is less than 50 kg, she needs 500 milligrams. But if her body weight is between 50 to 70,000 milligrams, and if the patient's body weight is more than 70, 1500 milligrams. But if the hemoglobin is less than 500, less than 10 grams per cent, even then, if the weight is less than 50 kg, she gets 500 milligrams. 50 to 70, 1500 milligrams, and more than 70 kg, she has to be given 2000 milligrams. Again, to repeat what I had told right in the beginning, the iron need in milligram of iron, as shown by Ganzoni's formula, body weight in kg multiplied by target hemoglobin minus actual hemoglobin in grams per deciliter multiplied by 2.4 plus iron for iron storage. Okay. It is recommended to use the patient's ideal body weight for obese patients or pre-pregnancy weight for pregnant women. For all other patients, use actual body weight. Ideal body weight may be calculated in number of ways by calculating weight at BMI, that is ideal body weight equal to 25 into height in meters square. To convert hemoglobin from mm to grams per deciliter, you should multiply hemoglobin in mm by a factor of 1.6. For a person with body weight above 35 kg, the iron stores are 500 milligram or above. Then they are at a lower limit of normal for smaller women. Some guidelines suggest using 10 to 15 milligram of iron per kg body weight. Default hemoglobin target is 15 gram per deciliter in Ganzoni's formula, but in special cases such as pregnancy, consider using lower hemoglobin levels. Now, there is something called as fixed iron need. Let the patient be anybody. You have a fixed let it be. There is a fixed iron need. A fixed dose of 1000 milligram is given to the patient, and she is re-evaluated for further iron need. According to step 3, post iron repletion assessment is done, and for patients weighing less than 50 kg, use a simplified table or Ganzoni's formula for iron need calculation. Then calculation and administration. Based on iron need determined as above, the appropriate dose or doses of iron, I3, should be administered taking into consideration the following. Total dose per week should not exceed 20 milligram of iron per kg body weight. Please remember this very clearly. Per week, it should not exceed 20 milligram per kg body weight. A single iron isomaltoside infusion should not exceed 20 milligram of iron per body weight. Then post iron repletion calculation. As I told you earlier on, how do you calculate this? Dose calculation and administration, post iron repletion assessment. Based on iron need determined above, the appropriate dose, I think we already finished this. Now coming to intravenous infusion, iron need required may be administered in a single iron isomaltoside infusion in up to 20 milligram of iron per kg body weight, or as weekly infusions. If the iron need exceeds 20 milligram of iron per kg body weight, the dose must be split into 2, and you can give it at least a week apart. Depending on clinical judgment, second administration could await follow-up laboratory tests. So administration rates for intravenous infusion is iron isomaltoside should be infused undiluted or diluted in sterile 0.9% sodium chloride, that is normal saline. For absolute stability reasons, iron 3 isomaltoside should not be diluted to concentrations less than 1 milligram of iron per milliliter and never diluted in more than 500 cc. Please remember this very clearly. Now, blood transfusion. Well, we all know WHO has stated that transfusion should be prescribed only for conditions for which there is no other treatment. Antepartum period, what is this? Period of gestation less than 34 weeks, hemoglobin less than 5 gram, with or without cardiac failure, congestive heart failure, hemoglobin between 5 to 7 in presence of congestive heart failure, and period of gestation more than 34 weeks but less than 7 grams. with acute hemorrhage. In intrapartum period, hemoglobin less than 7 grams, and postpartum anemia with signs of shock, acute hemorrhage, and hemodynamic instability with hemoglobin less than 7. We all know the risk of blood transfusion. We all know that you can transfuse various infections like HIV. Effectiveness of procedure, cost has to be kept in mind. Availability of blood is also equally important, and reaction to constituents. So, ladies and gentlemen, to summarize what I said, intravenous iron use in women of reproductive age has increased rapidly. Iron 3 isomaltose side is the only IV iron that can be given as 1000 milligram and above in a single visit. Faster and higher hemoglobin rise with iron isomaltoside as compared to iron sucrose. No test dose is required. Possibility of providing full iron repletion in a single infusion is there. In clinical and observational studies, no acute anaphylactic or delayed allergic reaction was found. And iron 3 isomaltoside is safe, effective, convenient. And lastly, the advantages: low immunological potential, low potential to release labile iron, does not appear to be associated with clinically significant hypophosphatemia, no test dose required, pregnancy category B, same as other third generation irons, only intravenous iron that can be given more than 1000 milligram and above up to 1005 milligram in a single visit. Possibility of providing full iron repletion in a single infusion, one dose iron repletion, less overall treatment cost, significantly higher and faster hemoglobin rise, and in clinical and observational studies, no acute anaphylactic or delayed allergic reaction. Thank you very much, ladies and gentlemen, for your attention. And we can have questions now.
Thank you so much, sir, for that very, very comprehensive, and I think it was an in-depth insight and a fantastic deliberation, sir. And so many, I think we learned so many points today that is gathering and finding that's contraindicated in first trimester, it's a big no. And I said 24 hours you stop, you're going to load so much of iron at a time. So 24 hours before all the oral supplementation need to be stopped and start them 7 days after. And the fantastic concept of that, the complex formation, and we really need to take this into consideration when we consider any iron preparation, and so that we don't have the labile ions and we don't have those toxic reactions. And of course, the upper limit of the dose is very, very high. So the number of doses decreased and that hypophosphatemia, the vitamin D levels not going to be disturbed. So I think we can sleep really well after giving this infusion to our patients. So, and 2 times maternal milk, this has the secretion, and it is very, very helpful. And so many advantages, I think, sir, and you've conveyed and we've learned so much from this presentation. Thank you so much, sir.
We need from our country more and more clinical data. At present, whatever papers that are published in international journals, they are all from abroad, majority of them. Though the clinical data, it has started in India, but as yet we do not have any paper published on this particular molecule from India. I don't know whether Pratik knows about it or not.
So thank you very much for a fantastic deliberation. Since you brought the point up, I have some breaking news to share with you.
Yes.
The first is that there have been limited studies which have been done on this particular molecule in the Indian population. Nearly 50 different clinicians in various parts of the country have tried it out. Nearly 400 Indian patients have received this. Not a single case of anaphylactic shock. Excellent results, as you reported in your talk. 2 grams per DL rise in just 2 weeks, and nearly 3 grams rise in another 4 to 5 weeks. So which is fantastic. And this is something which will be a game changer for the entire scenario of anemia prevention and treatment during pregnancy in India. The biggest silent killers of women in this country are hypertensive disorders, postpartum hemorrhage, and anemia. We have effective medications and ways to control them today, and that will lead the way for us to be one of the countries outside the Western world to have the lowest maternal mortality rates in the next 1 decade. Thank you so much, sir, for this
I
excellent
want to add
information.
something more.
Yes, sir.
When I was at KEM,
Yes, sir.
and when FCM came in market, that time I3 was not available.
Absolutely, sir.
We used to have all pregnant patients who delivered with us, we used to do hemoglobin. If it was less than 10, not 11, less than 10, we gave them 1000 milligram FCM and we sent her home. What happens is that if she has less hemoglobin, she will not come back to you. She will come back to you only if her baby has some problem. So I think now we have this I3. It's an ideal treatment for immediately post-delivery, even mild anemia. Forget about moderate. Even mild anemia. You give one shot, it will do a lot of good to a postpartum woman who goes home and she has to start working for her family. I think this is fabulous. Number two, I have been talking to all the manufacturers of these intravenous preparations. The cost is slightly high. I know in private practice, it doesn't matter. But when it comes to masses, in government hospitals, municipal corporation hospitals, when you ask a patient to buy 500 milligram of one injection, which costs anywhere from 2,000 to 3,000, she may not come back to you. So what should be done by our government, state government, or even central government? They should buy in bulk these intravenous preparations and make it available in all the government hospitals, municipal corporation hospitals. This will definitely reduce the pain, the fatigue, the postpartum anemia, all those problems that a woman has to face after delivery. And if Foxy can do it, take up with the Ministry of Health and Family Welfare and see that now with the latest molecules available, which is comparatively cheaper, comparatively, I am not saying it is totally cheap. I think they can negotiate the cost. The government should buy and make it available to poor patients. Sorry, this is Andaman.
Thank you, sir. We have the Foxy Food and Drug Committee chairperson here who is going to spearhead this initiative. And we have a future Foxy president in the shape of Dr. Archana Verma who will carry this mission forward.
So you start working now.
Archana ji, any comments, ma'am?
Dr. Pratik, I must say, India में एक problem है कि good thing. Like everything is starting with I, whether it is an I pill, whether it is an iPhone, it always is a hit. So Pratik, आज तुम्हारी I3 वाला तो तुम्हारा hit है program.
Thank you so much. We have nearly 1,600 viewers logged in from all over the world. And there have been numerous messages congratulating us for this experience series. So thanks to Science Integra, our background, and of course to Blisson, who are our education partner. Sorry, ma'am, I interrupted you. Please go ahead.
No. I was telling an idea से पहले दिमाग से निकल ना जाए. Integrated, यानी Science Integra के साथ that this very intelligently and impressive, I must say, today's webinar. She should write. अपने कमेटी के साथ लिख के ना अपना आयरन के लिए भी ना डाटा जो अभी पीके सर आप ना दो तुम्हारे एडवाइजर यहाँ पे जो सुपर सॉलिड है ना तुम्हारे को इतने सारे आइडिया दे दिए अमय पुरंदरे ने भी फूड फोर्टिफिकेशन के लिए. I think your committee is going to be the best. We should see to it.
Yeah.
Right. Thank you.
So with your permission, I'll proceed to the Q&A. There are quite a few questions and I'll just take them one by one. The first one is from Dr. Gulab. She's from Naigaon and she's asking about dose calculation. I think Dr. Pikesha went into it quite extensively and it was towards the later part of the talk. So maybe the question was posted earlier, but just to reiterate, Ganzoni formula 2.4 WD plus 1000 is the standard dose calculation, which we have learned since our MBBS days. There is no difference in the
think
formula.
yes.
The formula is exactly the same. Dr. Parul Goel from Ghaziabad, madam, आपकी दोस्त है शायद, is asking whether injectable iron can be given in first trimester of pregnancy. Again, I think this was answered during the talk. Dr. Purnima Yande is asking whether there is any anaphylactic reaction to parenteral iron. So the newer molecule which sir has just spoken about extensively, not a single documented case of anaphylactic shock, both in the Western world as well as whatever limited experience we have so far in India. The only important caveat to that is that it has to be given in a short time of about 15 minutes. Try and restrict the time to which you are giving the infusion. If you prolong it over many hours, and that can give rise to labile ions, as sir pointed out, and that can be a cause of hypersensitivity. So that is what is to be borne in mind. There is one question from Dr. Preetam Mukher from Mapusa in Goa. What is the preferred iron preparation for intravenous use? So unfortunately, I don't have the audience in front of me like in a physical conference. Usually I would do an audience poll immediately when such a question comes. And all of them would probably say, yes, I3 should now be the preferred intravenous iron, parenteral iron, which is available to us all throughout the country. As Dr. P.K. Shah sir has suggested, maybe it can be made available directly through indent in government hospitals, and that will ensure that it reaches the population of this country, the masses where it is actually necessary. Dr. Ritu and Dr. Archana are going to take this cause forward, and that will be the true success of today's program on Republic Day as far
Even
as eradicating anemia is
I'm
concerned.
thinking.
ये आपका पूरा इलेक्शन का मैनिफेस्टो हो गया मैडम और आपका ईयर भी प्लान हो गया.
No, both
अभी
of
इसके
you are.
वेबिनार के तुरंत खत्म होने के बाद ये पेरेंटल I3 इसी पे पूरा अब कहानी चल पड़ेगी और ऋतु के साथ.
I'm very serious when I say this.
Yes sir.
That both of you are closer to Delhi than.
Yes sir. Yes sir. सर आप बताएं, बस एक आइडिया दे दीजिएगा. वैसे nowadays I will talk.
No, I'm very serious about this issue. See, so many of you know the ministers over there. You come in contact with them. The Foxy office bearers, we have very close relationship, Foxy and the Ministry of Health and Family Welfare. So I think this is a time when we can do something in a very big way. And if this can be done, I am sure whosoever takes the lead will be given a lot of importance for lifetime. Padma Shri.
One final question is from Dr. Ashwini Gavande. She is from Yavatmal, and she wants to know about sickle cell anemia and thalassemia. Unfortunately, we didn't have time to address that in today's event, but we have taken your suggestions on board and we will try and address these in a future program. So before I conclude this entire event with the formal vote of thanks, I would like to share one more piece of information, and that is something which is pertaining to a contribution by one of our own AMOG's members. If I can just go to the slide, 1 second. Yeah. This is the Cross 11 app. It is available on the Play Store and it was devised by Dr. Gorakh Mandrupkar. He's a past chairperson of the Foxy Medical Disorders and Pregnancy Committee. He's from Islampur, a very small taluka place in Maharashtra. He was joint secretary with Dr. Suchitra Pandit ma'am when she was the president of Foxy. And his app is actually something which is designed along the Anemia Mukt Bharat guidelines. It is an integral component of the same. And this was inaugurated by Shri Shripad Naik, who was then the health minister. Thank you so much, Dr. Gorakh, for all your fantastic contributions. We are really proud of you, both in AMOGS as well as Mumbai Society, because once upon a time he was a Mumbai Society member as well. So these are just some screenshots from the app. These are very useful and these are designed for paramedical personnel and people from the interiors if they want information about anemia, what is iron deficiency, what are the food sources, and so on and so forth. It's called the Cross 11 app and it's available on the Play Store. Please do check it out. And if you have a chance, share it with your friends, colleagues, with your patients as well. Often in consulting, we don't have much time to educate people about what is anemia, what are the food sources, what are the important parameters that you look for. But if you have an all-in-one app that addresses that, then I think Cross 11 is probably one of the easiest and most accessible ways of doing it. I would invite closing remarks from all our distinguished faculty before I present the vote of thanks. Dr. Ritu ma'am.
Yeah, I think it was a fantastic session, and by this session and with the advice of our mentor, Dr. P.K. Shah sir, I think we'll take up this initiative, Dr. Archana madam with me, and we'll move up. One is to get more studies, more Indian studies will work up and to bring out the cost, and food fortification we've already started with Dr. Amya. So thank you so much.
Dr. Archana Verma ma'am.
Very nice, and so many ideas today conceived. So many, it's a wonderful concept to go ahead with the central pupil and taking taking a view wall and making something, because it is really very easy for, especially for me, to go to Delhi among all of us, and Ritu also. So, and nowadays somehow I will talk to Pratik, and I just last, I think 1 to 3 days back, I was talking to Ritu. And that's very easy to approach Ministry of Health nowadays.
Finally, Dr. P.K. Shah sir. Sir, you're muted, please. Please unmute.
We senior, we need
I
senior
feel that
person.
not only the gynecologists, the office bearers of various organizations of OBGYN, but also the pharmaceutical companies should make an effort. Ultimately, they want to sell their product. So I think the effort should be made by all of us to see that for improving women's health, for conquering anemia. See, it looks very great, Anemia Mukt Bharat and all that. Such slogans don't work. It is not going to happen. But if we can reduce it significantly, I think then we have done the job. So the gynecologists, all the organizations, IMA, ISAR, everyone can join. And even pharma companies who are manufacturing this should go ahead and see that the government is pressurized to buy in bulk so that it is made available to poor patients. Thank you very much, Pratik, for a very important topic being discussed on 26th January afternoon. And
thank you very much,
sure
sir.
something will come up in future.
Thank you, sir. Thank you for your blessings. And as the chairperson for the AMOG's Endocrinology Committee, it's my proud privilege to present the final vote of thanks. Today is a very important day, 26th January. It's a Republic Day, and I think it's important for all of us to focus on the important silent killers. Today's focus was anemia, and I'd like to place on record my gratitude to the AMOG's office bearers, our beloved President, Dr. Rajendra Singh Pardeshi, our Secretary, Dr. Sujata Dalvi, the ICOG office bearers, Dr. Lakshmi Shrikhande, who's the chairperson, Dr. Ashok Kumar, who's the secretary. Thank you for the 2 ICOG credit points for today's event. The event was graced by our Vice President of AMOGS, Dr. Amey Purandare, who gave very important pointers and acknowledged the role of all the faculty in fighting anemia throughout so far. Our chairpersons, Dr. Mandakini Megh, who is my zonal coordinator of AMOGS, and also somebody who we all respect immensely for the amount of work that she has done over more than 2 decades for Mumbai Society and FOXY. Dr. Ritu Khanna, chairperson for the FOXY Food and Drug Committee. I think she's taken a lot of important pointers for this program, from this program, and we hope that she has excellent tenure, whatever is left, and we hope to see her as the Vice President of FOXY very soon. Dr. Archana Verma, past Vice President of FOXY, and soon we will see her as the President of FOXY. Fantastic talk on the oral iron and the Indian perspective, all the different salts. When do patients take? Why are they non-compliant? What are the issues associated with it? And finally, that set us up very nicely for today's showstopper, Dr. P.K. Shah sir, our past president of FOXY and MOGS. Thank you so much for a fantastic talk on parenteral isomyeltoside, which is something we hope will go a long way towards eradicating iron deficiency and anemia from the masses of India. Last but not least, I need to place on record my gratitude to Science Integra, Subbu, Ganesh, and Sana, our backend team. Thank you so much for being there with us. not only during the program, but also before and after. Thank you also to our academic partners, Glisten, makers of injection I3, FE3XT, and IVMAG, on which we had the previous program. I also need to remind the audience across the length and breadth of the country that you have a fantastic certificate designed by the Science Integra team, which is waiting for you. As soon as this program is over, this can be availed of by clicking on the download button, or it can also be directly emailed to you at the address with which you registered. So thank you so much for joining us on 26th January in the afternoon for this lovely program. Until next time, goodbye, God bless, and take care.